It's lovely to be here. Thank you to Raul, to Robert, and to Tasso for having me. Now, I have a soft corner for audiologists. My wife is the senior audiologist and deputy manager at Alderhay Children's Hospital. So the only quandary which I had is that if I can't get one audiologist to listen to me, what chance do I have of 100 audiologists to listen to me? But I shall try and do my best to see if I can do something with that. Okay. So, excuse me. Now, without further ado, what I did do was I sneaked in this, and I thought it would be appropriate to start by paying our respects, to the Queen, and I'm sure you'll all join me in doing that. What you might notice that I have been cheeky enough to sneak in the photo of a hearing aid. There's a little arrow just showing that, so I thought that could be topical. Now, you must have heard of thousands of jokes about hearing aids, so I thought I could also slip in an old one. But this is actually more pertinent than it seems. When I talk a little bit about dementia and hearing loss, maybe this becomes more relevant. So I think that the ear is the most wonderful ear, and I am, a sort of great devotee. This is Alwyn Alexander's tribute to Van Gogh, to Vincent van Gogh, or Van Gogh as you like, and this is his own interpretation of, his ear. So, sound is an amazing thing, isn't it? It's enabling us to do this course. We take it for granted, isn't it? But we can never undermine the importance of sound. Your favorite song, the laughter of a child, and now as time is passing, we are knowing more and more about how important sound is for the human brain, much more than we thought. Music is called the physician of the future. In fact, I have a book which says that. Now, we know that sound is really important for healing people, for people who are in coma, for people who have autism, and more so now is coming in for people who have dementia. Besides the neural plasticity, we know it's so important in children. And just in case we've forgotten, let me show you this. So this is a child who's just had their first hearing aid switched on. I can't overemphasize the gravity and the importance of this moment. Now, I mostly speak to doctors all over the country. I've spoken to about 14,000 GPs till now, and over the length and breadth of the country, how good are GPs at examining the ear? There you go, you're absolutely right. So we're really, really terrible, but that's because of posterity of teaching. No excuse though. I'm sure you guys are a lot better. But I'm always going to start, as I always do, with basic anatomy, because if you don't know what a normal eardrum looks like, everything else is conjecture thereafter, isn't it? So let's start. Everybody happy with this slide? Which ear are we looking at? See, you're all confident. And all of you know what this is? Great. All of you know what this is? Yes or no? Can you shout out, please? Fantastic. So this is the lateral process of malleus. And this, of course, is the handle. That's the umbo, and that's the cone of light. What is this? And what is this shadow? No, the round window is there. That's the shin tube opening. Now, this is really important to know this. And you can see the normal translucency and sheen. You're all right. What is really important is you must always identify this little white knob, the lateral process of malleus. Because what's happening here and the pathology in this part of the eardrum is managed totally different from pathology up here, which is the region of the attic. So it's really important, and this is just a schema from the Gray's Anatomy. You can see the lateral process of malleus. This bulk is called the pars tensa. There's the incus, and that's the pars flaccida, or the attic. I'd like to show a few slides. Again, you can see beautifully the lateral process. You must always look at it. The reason to know the configuration, obviously we know which ear we're looking at, but the reason to know the configuration is that in a normal ear it's easy, but when there's pathology, then you will get lost if you don't have this clear in your mind. So another perfectly normal right ear, now a left ear. This one shows the attic really well. Would you agree? So that's beautifully seen. Once again, you can see the incus and the eustachian tube opening. And of course, those are beautifully magnified slides, but what you would normally see, what I think you guys are used to seeing from your otoscopes and your rigid otoscopes is this. But the point here is, even in this, you can identify all the normal structures. So I would suggest, please always go for the handle of malleus, always check the lateral process, and always look above it to see what's going on. And I'll show you the reason why. Now, the Japanese are very clever. They've got these very fine, fiber optic cameras, and they pass them up the eustachian tube into the middle ear. And that's what the middle ear looks like from inside. You can see that's the medial aspect of the tympanic membrane. That's the lateral process, and the handle of malleus, the incus, and the stapes there, the long process of incus attaching the stapes to the oval window. And that's exactly what we're really seeing on this photo. Now, what about this? You all know your eardrum well. What's wrong with this picture? Well said. The gentleman says the light reflects. Yes, the cone of light is not in its normal place, which in the right ear would be about 5 o'clock. It's horizontalized. It's displaced at 3 o'clock. Now, what does this mean? This is the first stage of retraction of the tympanic membrane. When the tympanic membrane starts to retract, the first thing that happens is that the cone of light gets distorted. Now, I thought I would bring this very important slide to you. You all know what this is? Yeah. So this is really important because certainly GPs are always amiss with this and they call this anything, So it's very important to know about this common white plaque or white patch that you see on a tympanic membrane. And this is tympanosclerosis or meringosclerosis. And what does it mean? What is the connotation? It's basically a telltale that something happened, an infection, a meringotomy, a grommet, a perforation. This is a healing, a reparative process. And if you don't know what this looks like, you're going to think this is something else that is going on and refer accordingly. This opacification which you see, this is quite normal and common and often seen in slightly aging tympanic membranes. In this case, is this tympanosclerosis causing any hearing loss? But as you all know, it can cause maximum conductive deafness. It can cause ossicular fixation. That's how extensive tympanosclerosis can be. And this is the last anatomy slide that I'm going to show. So when I teach GPs, I ask them to take 2 minutes and have a look at this slide. And if they can tell me everything about this slide and this picture, then they are good to go. You guys need only about 10 seconds, okay? But let me show you a few things. The handle of malleus is very prominent, very sharp. If you see the anterior edge is very sharp. Why? Because the tympanic membrane is slightly retracted and draped over it tightly. And that also makes the lateral process very prominent. Is that right? If you see the cone of light is decimated, and you can see this extensive horseshoe-shaped tympanosclerosis. What else are you seeing? Wonderful. Somebody said attic retraction. Would anybody like to disagree with him? They're all scared of you. Right. That's right. A lot of people call it an attic perforation. Would they be wrong? No. Because it doesn't really make much difference in the management of this. But this is an attic retraction, and you know it. As you can see, we are looking now above the lateral process. And why it's a retraction is because you can see a light reflex coming from the bottom of the pouch. Is this going to grow up and become anything? A cholesteatoma? We don't know. But if you guys see this, please refer the patient. It's very important for you to refer it. Because, as you know, we get lots of referrals about abnormal tympanic membranes. But I'm trying to take you that little step further to know a little bit more, distinction and discretion about what a really an abnormal tympanic membrane looks like. Okay. And to start off with clinical conditions, a very, very important condition called glue ear. And it goes by various names: secretory otitis media, serous otitis media, otitis media with effusion, and middle ear effusion. The latter two are the ones which we use as ENT specialists. Now, what does that mean? Basically, there is fluid filling the middle ear. What do you see which is different in this slide from all the ones I've shown you thus far? The color. Would you agree? The color, the hue. So you can see, can we do these lights a little bit dim at all, if possible, guys? I don't know if it is, but so if you see there's a yellowish hue filling the whole of the middle ear, this is classic glue ear. So the classic glue ear is straw-colored fluid. That's classic glue ear. It's completely fitting. Again, you can see a slight attic retraction, the attic just there. Now, glue ear is, of course, as you know, is very, very common in children. 80% of all children in this country will get glue ear at some point. And obviously, that's why I tell doctors not to miss it. And I'm sure you guys will see plenty of it. But it has various presentations, and you might need to know all these in their own different ways. What do you see here? Sorry? The bubbling, fantastic. Like, you guys are too good. I mean, I think I should have prepared a longer lecture now. So what gives away the slide, the answer here is the bubbles. As it is, the middle air is a big air bubble, isn't it? But you never see the air. The only time you'll see air is when there's a presence of fluid in it. So here you can see the 3 bubbles which give way, and a slightly lighter colored but yellowish fluid here. So whenever you see bubbles, there is fluid behind the tympanic membrane. This again is glue ear. What about this one? Can you see anything else besides retraction? Fluid. Air fluid level. Can you see this? So once again, you can see air fluid level with a little bit of effusion at the bottom. Once again, the diagnosis is middle ear effusion or glue ear. This is a really important slide. If I was to remove these arrows, would you really think much is wrong with this ear, except that it is retracted, because you can see the handle of malleus is a little bit foreshortened. Foreshortened means the handle of malleus is taken backwards. So this is slightly foreshortened, and you can see it's definitely retracted. But if you don't look carefully, you will miss the air fluid level. Why? Because the fluid here is very, very thin, very serous, almost watery. So you will not expect a dull drum. You will not expect the yellowish hue or the bluish hue or the significant dullness. If you don't look carefully, you will miss this again. This again is glue ear. Easy one. Quite typically how glue ear is often seen. Very dull drum, a few stray blood vessels, but this is not really inflamed. Even more opacified. But again, there's no inflammation. If we do a myringotomy, we'll get turbid fluid. But what is the diagnosis? The diagnosis still remains glue ear. So please be aware of the protein presentations of glue ear. What is really important from your side is, if you see an adult glue ear, which is on one side, it's an urgent referral again. Okay? The attic retraction is not an urgent referral, and attic perforation is not an urgent referral. It is a referral. But an unilateral glue ear is an urgent referral, because we need to exclude nasopharyngeal carcinoma, which could be obstructing the eustachian tube opening, hence resulting in this. And especially people who come from Southeast Asia, people of Chinese origin. In China, a unilateral adult glue ear is nasopharyngeal carcinoma unless proven otherwise. So, and they carry that risk. Even if they immigrate, they carry that risk. So please be aware of that. So that's all about glue ear. Obviously, I don't want to tell you anything more, because you don't need anything more from that from me. A word about grommets. Obviously, they are of various kinds. And depending upon the shapes, size, the flanges and the T-tubes, there are different indications and for different periods of time that they will be in. If you want to know more, we can do some questions. But basically, we often put them in the anterior-inferior part. The theory behind that was perhaps as close to the eustachian tube, but you can see them in various other places which people put them in. They have their own complications and their own issues, which perhaps we don't need to go into from your point of view. Now, I thought I would mention a little bit to you about otitis media, because you might be seeing, and because you see so many patients and you look into every year, you might see this in its various presentation, in its various modes, and in fact, in its various stages. And what might this patient present with? That's right. This lady said a bit of discomfort or pain. Yes. What we can see here is that the handle of malleus is congested and inflamed. The other eardrum is dull, but nothing else going on. Perhaps a little bit more earache. So if somebody presents, I'm just trying to show you, obviously I'm not going to the treatment, but if somebody tells you and you have a look, you think, yes, there's something going on here. Perhaps a little bit more otalgia. A slightly hemorrhagic handle of malleus with a little bit of cartwheel inflammation. Again, perhaps more symptomatic. A bit worse. Classic acute otitis media. Again, most of these don't need treatment. They will settle down, but I won't go there. But this is typical. You can see that there's inflammation. There's opacification, is obviously fluid, but this is inflamed. Unlike the glue ears where there was no inflammation. We are always, unfortunately, as doctors, intervening too early. We don't need to. Why? Because things can get a lot worse. Opacified, full of pus, the umbo is depressed, even the attic is bulging. Lot more pain, high temperature. Again, you can see the inflammation. Again, pus behind the tympanic membrane, posterior inferiorly, anterior inferiorly. Whole of the posterior quadrant inflamed and bulging. And sometimes when they go on its own, we're left with a perforation. Natural resolution. The treatments vary from time to time. I know you guys are not interested, so that's perfectly fine. But just I thought to let you recognize these bits. So this was really a bit of a journey from, normally ENT consultants don't see this. It's only the domain of primary care. So when I teach primary care, I show them the journey because they see patient severity level. So a normal looking, or normal, it's not completely normal, and all the way to an acute otitis media with purulent material behind the drum. Here's an important one. Because, you know, what I have found, which is really strange, which I don't know if you know this, but you guys send these beautiful pictures to GPs. You've taken through very nicely and very conscientiously. And when we get a referral, you know what it is? 3 or 4 large black dots that we are attaching a copy of the images of the tympanic membrane. There are no images. You just see black holes. So again, can you see a lot of tympanosclerosis? Now this is a central perforation. So nothing for you to worry. And why? Because you have the margin of tympanic membrane all around it. So central perforations are not worried. This is safe chronic otitis media or chronic suppurative otitis media. But let me take you to a different level. And this is important, perhaps one of the reasons why I might be useful here. Can you see this left tympanic membrane? And you can see this marginal posterior superior perforation. Again, a right ear, marginal posterior superior. Of course, you can see beautifully the incus, the head of stapes, and the stapedius tendon there. Can you see that? That's actually the chorda. So, posterior superior marginal perforations, number 1. How about this? If you look casually at this tympanic membrane, you will say, a little bit retracted, cone of light is, but if you don't look above the lateral process, you will not see this large attic perforation. Again, if you don't look carefully, oh, there's a little bit of a tympanosclerotic patch here, congested malleus, I'm not interested. Cholesteatoma, frank. And here, not only is there cholesteatoma here, can you see it behind the drum? So that's the cholesteatoma in the mesotympanum also. And again, an attic crust in the right ear. So all these 5 slides are what is called chronic unsafe otitis media, chronic unsafe suppurative otitis media. They all need referral for intervention or maybe observing. Very important what kind of procedure is done, but that's not important, but they should be referred. So I hope that you will look at the attic a little bit more and refer them accordingly. I shouldn't have put that up, isn't it? So this is what is the sign of the rising sun. So the commonest tumor in the middle ear is glomus tympanicum, which is a glomus tumor, which basically are paragangliomas, which are basically neuroendocrine tumors. I don't think you want to know more than that. But if you see something, if you see a shadow, a partial shadow or a full shadow, or a redness or a blue shadow behind the tympanic membrane, be suspicious. If it is red particularly, this is classic glomus tympanicum tumor, which needs a referral, needless to say. But sometimes you might see just a blue shadow. And that may or may not be abnormal. It can simply be what is called a highly invested jugular bulb, which is present in 5 to 10% of population. And you will not always see it. The visibility is not in 5 to 10, but you have a highly invested jugular bulb. In many cases, nothing is required, but at least you will be aware of it and you can refer the patient if necessary. When you look at the ear, you'll see lots of ears which are dry and scabby with otitis externa. That's, I think, the norm for you to see. But if you see something like that, a little bit of a fleshy lesion, a little bit of an inflamed lesion, but there's no discharge here. There's no, in the early stages, of course, there's no pain. This is a squamous cell carcinoma of the ear canal. So please always be aware of the possibility of something like this. Is that all right? Now, this is something I'm sure you see a lot of. Otitis externa. So I'll keep this very simple. You can just split it into three kinds. Localized and diffuse are the main varieties. And then what we used to call malignant otitis externa, which is not malignancy, but now the term has been supplanted by necrotizing otitis externa, though the old school still uses the word malignant. So localized is very simple. 1, 2, 3. Can you see? So localized basically is furunculosis, and the giveaway is the hair follicles, because that's where it originates from. The canal is quite narrow, almost slit-like can be, but there's no discharge, there's no redness as such, but it's extremely painful. If you touch the tragus, they'll hit the roof, and they might hit you too. So now a little bit more advanced, you can see a little bit more of a bulge, and then slight pointing, and here this is a furuncle which is fully developed, might need lancing. So just to remember, localized otitis externa. So tracheal tenderness is a good sign to use in for otitis externa. And then we have the diffuse variety, which is also extremely common. And you can see the whole of the ear canal is inflamed, a little bit of debris, and some muck right at the end of the tunnel. The tympanic membrane is probably intact unless there's a history. So you can have a case which is like this, or you could have it like this, which is really very severe. The ear canal is very narrow. Obviously, we have to manage them differently because it's not easy to get medication into a pinhole, so they are managed slightly differently. And one for you to know, if you see somebody complaining of symptoms and you see lots of blackish muck or lots of whitish spores, which can be either in a string or like cotton ball, so you can have aspergillus, which can be black or white, and of course candida, which is white. So do remember otomycosis or fungal otitis externa, and that's very important, especially if you see diabetics, people who have athlete's foot, and so on and so forth. Now, if you ever see a patient who says, got severe pain in my ear, severe pain, these are usually elderly, debilitated, frail, may or may not be diabetics. It's not always diabetics, but the very elderly, the very frail, extremely painful condition with a little bit of blood-stained discharge. And when you look into them, you see granulations on the floor of the external canal. Okay? This is a very, very serious condition. It has a 50% mortality. Believe it or not, yes. So this is a medical emergency. So you need to refer them immediately to hospital. My wife knows one of our friends, their father, who was a doctor himself in Bombay, he died of this condition. So you have this spreading cellulitis along the skull base with progressive cranial nerve palsies. They're quite unwell. They're not right. They're febrile. So you must be able to recognize this condition. Again, you need to tell them, go to the hospital or go to your GP now. So that's really, really important. Now, really important topic. So, if somebody comes to you, this lady, this lovely lady, you've been seeing her for many years, and she says, I woke up this morning and my right ear, doc, I can't hear a damn thing out of my right ear. And you look at her ear and the tympanic membrane looks fine, if you're lucky. If you have wax, you're in trouble. Well, not all of you, I suppose, those who can clear. If the tympanic membrane looks fine, what are you going to worry about? Now, this is really important. Yes, fair enough. So basically, you are really worried about sudden onset sensory node hearing loss. Now, why you need to worry about it is because the medico-legal cases about sudden onset sensory node hearing loss are skyrocketing. It's crazy. I don't know. I find that the incidence has increased greatly. I know that because I triage about 500 referrals in the Northwest every month. You can imagine. So I triage so many referrals every month, at least 500. And so many times I have to write to the GP. I get routine referrals for sudden hearing loss, believe it or not. But you can't have that because the time window is critical. So if somebody comes like that, obviously I tell them what to do, what to examine, how to use tuning forks, but you guys don't have that problem. You can just do a hearing test. So you're the lucky ones. But if you ever see that and you suspect sudden onset hearing loss, either you send them to A&E or to their doctor straight away. They need to have steroids immediately. And of course, there are various other regimes and modalities, which I can just mention to you. So it's really important. And how do you define sudden onset hearing loss? So I've made up this rule of 3 because it is really important to remember. The onset must be within the last 72 hours. If somebody says, I've been losing my hearing for the last 3 weeks, no, that's not sudden onset sensory hearing loss. It has to have developed fairly rapidly. That's why it's called sudden. So it has to be 3 days. There has to be loss in at least 3 frequencies when you test them, and the loss must be at least 30 decibels. So I have seen some sudden hearing loss. I had a referral recently. There was barely any 5 decibel hearing loss and referred at sensory hearing loss. And I said, nobody's going to do anything. It's so negligible. We don't know what's the cause in most cases. And as you know, when doctors don't know what the cause is, let me give you a hint. They go for these 4. Okay? So we don't know. Could be vascular pathology, must be a virus, or autoimmune. That's what we go for. But anyway, the key is steroids. Of course, transtympanic dexamethasone is also used now. This is perhaps a useful tip for you. If somebody lost their hearing 4 weeks ago, or 5 weeks ago, and came to you and said, I've suddenly lost my hearing, don't think that all is lost, because they can still have intratympanic steroids up to 6 weeks for salvage. Okay? So please just remember that. In case you see somebody with a later presentation, still take whatever action as swiftly as you can. Is that all right? I won't bore you with the list. Now, this is the NICE guideline. It's a very, very, well, not unlike a NICE guideline, let me say it this way. So here's the guideline. So sudden hearing loss. So if the hearing develops suddenly, again, exactly as I mentioned, over a period of 3 days, in the last 1 month. So if it happened 25 days ago, but happened suddenly, they still need to be sent as an emergency within 24 hours. So somebody said 3 weeks ago, I lost my hearing, it's still a medical emergency, okay? But if it was sudden hearing loss, but more than a month old, okay? It was sudden. So 2 months ago, suddenly had a hearing loss, it's still an urgent referral because it's still sudden hearing loss, still develops suddenly. But what about if it's rapid hearing loss? Now, this is where the plot thickens, really. What is rapid hearing loss? If it developed over a period of 4 days to 90 days. So if somebody says, I've lost my hearing over the last 2.5 months, it's still rapid hearing loss. This is as per NICE and still needs an urgent referral. So I hope this is useful for you. But the point I'm really trying to make it is, please don't miss sudden hearing loss. Please keep alert for that. A lot of doctors miss it, and they really still don't know how to deal with it. So yeah, I won't go there, but steroids, and it's the same thing from America. It's exactly the same guideline. Now, I don't know how many of you know, but there was a very nice guideline which came out in June 2018, and it had lots of components, which included sudden hearing loss and so on and so forth. But one really important thing, which is close to my heart because I'm so interested in sound, is to do with this. So what we are finding now is that hearing and sound is so critical for our well-being, so critical for our aging, so critical for our old age and health. You cannot even imagine how important it is for our neural health and neural development, much more than was thought. So sound, that's why I was saying, is such an important phenomena. Okay, so here is a really important guideline, but who's really following this up? That's the question. So consider, that's the problem, adults with diagnosed or suspected dementia for audiology for a hearing aid test. I think every patient with cognitive dysfunction must have an audiogram. I really tell you, must, because if they don't, deaf people with dementia go like this. It is so important to sustain them, to help them. It's much more important than the tablet which we prescribe for dementia, let me tell you. But who's going to listen to me? So that's really important. Now, that's really important. And every 2 years, if they don't have a hearing aid, they don't have hearing loss, every 2 years. Now, nobody has taken the mantle on this, not the ENT people, not the GPs. I'm not sure you guys have either, but there is a huge need for this. And here again, consider referring diagnosed or mild for every 2 years, and including people with learning disabilities. So I think anybody who has a deficit in their brain of any kind, I think it's really, really important that we think how important the hearing is. It is absolutely critical for our brain and neural health. Okay? Right. What do these people have in common? Who said that? Anybody else? Sorry? Tinnitus, dizziness. Well, let me tell you, a few years ago, I was in Middlesbrough, and I was teaching, doing a workshop in the morning, and I showed this slide. And there was a lady in the first row, and she got up and she said, she didn't get up, but she put her hand up and she said, they all have only one testicle. Now, 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 we know that Adolf Hitler had only one testicle. Perhaps that's why he was so pissed off with the whole world. But I said, I don't think that Eric Clapton or William Shatner would be happy to know that they have only one testicle. Anyway, so indeed. So this is a case scenario which I often show. So, somebody calls you and says, hi, doc, this is Mr. Bond, Mr. J. Bond, and I've got this buzzing noise in my ear. Do I have anything to worry about? So tinnitus is an extremely important 6% of the population. Thousands and thousands of people have tinnitus, and it's very, very serious. And please take it seriously. I tell people, if somebody phones you and says, I've got this noise in my head, and I can't cope with it anymore, doctor, you need to see them as same as a patient who says, I think I'm going to kill myself today. Because people have committed suicide because of tinnitus. I remember about 10 years ago, one of my own patients, he died last year, unfortunately, came to me, and I knew him very well, and came to my GP surgery, and he said, doc, I've got this noise in my head, just 3 days history. Normally, nobody would scan. He said, it's just driving me crazy. The expression on his face and the way he spoke, I did a scan. He had an 8-millimeter neuroma, acoustic neuroma. He was operated, but he developed so much trouble, he never left his house for 9 years till he died. It was such a difficult thing for him, because tinnitus may not go. So what should you do? So I'll tell you some few interesting facts about tinnitus in a minute. So there's obviously some obvious causes, as you can see. Now, what are the causes of tinnitus? So basically, tinnitus loosely, I'm sure all of you know, is subjective and objective. More than 95% of tinnitus is subjective, i.e., only the patient can perceive it. Whereas 5% maybe because of vascular causes and AV malformations and palatal myoclonus, and in which case sometimes the partner and the examiner can also know what it is. But if you look at either of them, if it's unilateral or bilateral, and of course it can be pulsatile. And pulsatile is interesting. If somebody ever tells you that I have a whooshing noise, I think it's important to just pause and ask them, what do you mean about a whoosh? Because you must say, is it a whoosh, or is it a whoosh, 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 or boom, boom, boom. So that's very important. You must always ask them, is it an intermittent or sound or not? Is that okay? But if you still see whether it is pulsatile, non-pulsatile, the most common cause is idiopathic, 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 idiopathic. But that's true. The reason for that, this is not one of those idiopathics. This is one which we can't find a cause for even when we hunt for it. But obviously, we are most scared of unilateral persistent tinnitus. All unilateral persistent tinnitus. And how do you ask them, is it persistent? You have to ask them, do you hear it night after night after night? Because a lot of patients will say, oh, no, I hear it only at night. It's not there all the time. Well, it is there all the time because you're hearing it when everything is quiet. So that makes it constant. So if it's unilateral and constant, it 100% needs investigation, number one. And if it's pulsatile, whether it's unilateral or bilateral, it 100% needs investigation, not necessarily urgent. Is that okay? So just remember this about tinnitus. Noise exposure, of course. Presbyocusis is the number one cause of bilateral tinnitus, which is benign. As we know, there is damage to the inner ear, inner hair cells, and obviously that creates the problem. And similar high-frequency hearing loss with noise-induced, which generates the tinnitus, so to speak, loosely. But there are various causes, and Meniere's disease, as you know, is also one of the causes. Don't forget the drugs, patient all, but I suppose you don't need to get into all of that. Remember vascular causes for pulsations, and for objective tinnitus, I think we mentioned a few bits. So this is generally just maybe a little bit out of your realm, but just make sure that it's nothing that you should worry about when you see a patient. And if it's unilateral, persistent, I know most of you make great referrals already on that, but just be able to. I wanted to tell you a little bit about tinnitus, which is not well taught, not well known, even amongst ENT surgeons. So why do we have an ear? The ear was developed as a flight and fight organism, isn't it? It was for us to hear the enemy, for me to hear a dinosaur. Well, maybe that's getting too far. Maybe a lion or a leopard, and run away. So that's what the ear was. So all of us have tinnitus, all of us, but we don't hear it because there's a cortical filter. But when something goes wrong in our lives, something goes wrong, stress, when there's something, then then your brain is attentively seeking a danger zone. Your brain is attentively seeking a problem. That's when it finds tinnitus. So a huge majority of tinnitus, believe it or not, is because of a cortical auditory perception disorder. And because you looked at the ears are normal, the hearing is normal, there's no hearing loss at all, there's no cause of it, scan is normal, MRI is normal. What's causing it? You could ask yourself. Then there is a somatosensory cause. So a lot of cervical TM joint pathology can trigger tinnitus. This is classically high-pitched unilateral, again, normal hearing, and often aggravated by Valsalva, aggravated by clenching the teeth. So those are the kind of people who might have a somatosensory disorder. And of course, the one which we all deal with, most commonly and familiar to all of us and to people like me, is the inner ear. So I hope that gives you a little bit more idea about a different kind. And this is, of course, Colin Hoffen. He's a German ENT surgeon who's been treating tinnitus only for the last 25 years. You all know this? Exostosis is a benign condition. Nothing needs to be done as long as it's not troubling. You can see the tympanic membrane is there. It's not obstructive. Some people keep getting trouble with excessive wax which gets stuck, otitis externa and infections, in which case simple surgery is done, very easy, just raise a flap, drill the bone off, put the flap back. It's pretty simple to treat. I'll just skip. Would you like me to touch on Baha and cochlear implant just a little bit? So two great aids, one for conductive or mixed hearing loss and one for sensorineural, the Baha and the cochlear implant. Now Baha is becoming more and more popular, and believe it or not, Chester, who does Baha in our region, has a waiting list of 4,000 patients. That's crazy. I did a Baha in 1994 when I was a registrar. You can see how old I am now. Okay, and I did a cochlear implant, by the way, in 1995, but I haven't done any since because last 20 years I've been in general practice. So Baha is useful in anybody, perhaps more than a hearing aid. If the airborne gap exceeds 30 decibels, you can find that Baha will give you the benefit. Again, same mixed deafness, but you need an airborne gap, of more than 30 to 35 decibels to have it more beneficial than air conduction hearing aid. It can be used in SN deafness. They say up to 65, but practically it's up to 55 decibels hearing loss. And also for single-sided deafness, it is very good because, shadow effect. So when I was telling you about how important hearing loss is, even hearing loss in just one ear has a significant effect on the brain. People keep saying that 1 year is enough, because Julius Caesar had only 1 year and he was okay, I guess. But it's not. So Baha can be very useful because you can pick up sound from one side and transmit to the other. So it's also indicated in single-sided deafness or shadow effect. Cochlear implants, of course, you need to have severe to profound hearing loss. We're talking about 80 dB plus, and you can harvest no benefit with conventional hearing aids at all. You've tried everything and nothing works. But that's only a small part of the picture. I think in cochlear implants, what follows after is really important. And it's how motivated the patient is when you do it. Are they postlingual deaf? I'm sure you all know that. But please be aware of it. So don't hesitate to write to your doctor colleagues or whatever that, do you think this patient will have Baha? So people who have persistent otitis externa just can't tolerate hearing aids, who have chronic stenosing otitis externa, the ear canal is closed off, people who have atresia, microtia, all those people can certainly benefit with intervention of a different kind. So never hesitate to refer them for that. Right? Well, this is from an exhibition in Beijing, and I thought it was rather interesting, given the size of the earphone which they've made. So this is taken from a retro exhibition, apparently. So, ladies and gentlemen, I think the ear, sound, and hearing is so very important. I think you're in an amazing field, I'm a big fan of the ear and of sound and hearing. I think it's so important, and Helen Keller, I think, has put it is very, very aptly, and I think for communication, certainly the ear is number one. But just to let you guys know, to change the tone a little bit, I think we might have just missed the bus for now, but God knows what's going to happen next year when the energy bills go up. And doctors are not always good. I'll leave you with a little video. I hope we have sound. Okay.
If you felt ill, what would you do?
Go to bed.
But before that,
Take the clothes off.
you would go to the doctors.
No, no doctor. Doctor killed my uncle in Madrid.
Really?
See, my uncle, he has pain in the chest. He goes see doctor. Doctor, he listen and say, it's all right. 10 minutes later in the street, my uncle, finito.
What, a heart attack?
Motorcar.
Well, you can hardly blame the doctor for that.
See, the doctor, he was driving the motor.
If you felt ill,
Thank you for listening. Thank you very much. Thanks. Any questions? Yes. Fantastic question. Post-COVID, have we seen any changes in the unilateral hearing loss, tinnitus, dizziness? Yes, we have. And sudden hearing loss. I must say, not as much as I would have expected, but yes, there's definitely people who get tinnitus, definitely people who get dizziness, people who have had sudden hearing loss also. But I'm not sure there is an increase in frequency from what I was seeing prior to that, because I watched it carefully. I actually got involved with Inter-University Hospital to see the effect of COVID because they got in touch with me into the community. But I can't say that I can say there's a definite distinction. There are lots of sporadic reports, lots of publications, but there is still the evidence is not strong enough to say what the true link and outcome is in terms of that. So we'll have to see.
I don't know about anyone else, but locally I have a real problem with GPs actually physically looking in my patients' ears. I have them prescribing antibiotic after antibiotic when it's not responding and they're still not seeing patients. Is there a way that you would recommend to gently suggest to GP practices, without treading on toes, actually bloody see the patient in a clinic? Because you can't diagnose over the phone when you need to look at it.
I'm so happy that you all heard that. I'm so happy she said that, because now I can also use the word. I keep telling GPs, bloody examine the ear. Because like I just told you, I see referrals and referrals. And they've done it over the telephone. Patient has tinnitus. Well, look into the goddamn ear first. How can you send the patient to me, not even bother to see, at least see what's going on? There could be a tumor. There could be, a glomus there. There could be a cholesteatoma. And there is absolutely no indication, either through COVID or now, not to examine the ear. Examining the ear is not an aerosol-generating procedure. You wear a mask, you have a look at the ear, and they've continued to do it. In fact, I chaired the Royal College Conference just last month, in London, and I made a remark that GPs are hiding behind COVID. And one of the delegates got very upset with me. He actually wrote in the feedback, that was the only negative comment, that please don't say this when the rest of the world is saying the same. Well, why not? Because there are some GPs, not all, I must say. I mean, I'm a GP myself. But I don't think that you shouldn't ever use COVID as an excuse, at least now, of not examining the patient, which continues to happen. So thank you for raising that. Yeah.
Hi, thank you. It was terrific, thank you. I have had a few patients recently that, that find they've got tinnitus and been investigated, but it's still disturbing 4, 5, 6, 10 years later. When is it appropriate to review them medically with scans and things again? You know, just in case it was too early for any of these organic causes. And the other one is, how do you approach a GP that's had somebody on CERC for 20 years?
Who's had some? Did you all get that? Okay, so tinnitus, when is a good time? I think, first of all, you must make sure that they are investigated appropriately. I have slides, obviously. I have 4 other slides of tinnitus, which I've not shown you because I didn't think that you get there for that. But anybody, like I mentioned, anybody with unilateral, persistent tinnitus needs investigation. If somebody has bilateral tinnitus, the likelihood that it is sinister is very, very remote. It can happen with bilateral pulsatile, but again, unilateral pulsatile. So those guys must be investigated. Once they're investigated and the MRI is clear, it's highly unlikely you need to investigate them for years. But the important point which I can get from what you were saying out of this is, tinnitus should not be ignored and say, live with it. I don't think those 3 words should ever be used. There's a lot that can be done. First of all, there is sound therapy. And there's some fantastic apps now, T-, Quiet, and for example, there are lovely apps which you can get, and there's lots that you can get to help you. So sound therapy is a great thing. But I think what investigation does it reassures the patient that, look, we've looked into your brain in a year, everything is tickety-boo, you have benign tinnitus, it's a damn annoyance, but we can manage it from here. So never belittle it and never say live with it. I think that's really wrong, or nothing can be done about it. Then there's medication. So if people who can't sleep, then there is no harm in asking their doctor to prescribe low-dose SSRIs or low-dose amitriptyline. That's a great help. And obviously, if people, as you know, in the guidelines is now, CBT is enshrined strongly into guidelines, digital CBT, group-based CBT for tinnitus, individual CBT for tinnitus, which has sort of superseded what was called tinnitus retraining therapy, as you know, in the olden days. So I think it's very important to make sure that these patients get that. You see, there are some symptoms which, because they don't kill the patient, they are just brushed under the carpet. It's all about diabetes and cardiovascular disease on this planet. Sorry? Yes, absolutely. They get more money, so, that's where the squeaky wheel gets the grease, unfortunately. So that's where it is. Now, your second question was?
Sir, they've been diagnosed with Meniere's 20 years ago. It's probably not. It's probably BPPV or something.
Okay.
But there's been
No follow-up, yeah. So Meniere's and CERC. CERC is beta-histine, as you know, which is a histamine analog, which actually works by releasing histamine. Now, CERC was specifically created, or beta-histine, for Meniere's disease. So that's perfectly fine. It can be used. It's meant for long-term use. It is meant because Meniere's is a chronic recurrent condition. It's not a condition which goes away. Some people are lucky. They'll get a remission for years and then again, back and again. So
they have no evidence of there being hearing loss in style with Meniere's, nothing else, and they just say it's Meniere's and give them beta-histine, and then you're looking like...
yes. So that's a different kettle of fish. So she's talking about some GPs have just diagnosed Meniere's. First of all, it's in the guideline. If a GP suspects Meniere's, the patient needs to be referred. That's number 1. That's well enshrined in the guideline of hearing loss. So that's very important. Number 2, yeah, you cannot just diagnose Meniere's like that. Obviously, I didn't bring Meniere's, but I do a dizziness lecture. So Meniere's has to be diagnosed by certain criteria. And there are certain absolute criteria and original criteria by Prosper Meniere, who was a 19th century physician who actually worked with Dupuytren. Dupuytren is a chap who diagnosed Dupuytren's contracture. There you go. And then he was the chief physician of the Deaf and Mute Institute in Paris. Anyhow, so he gave a triad that you had to have hearing loss, tinnitus, and dizziness. Now, those 3 criteria don't hold any true. Fullness of the ear could supplant one of the others. But a lot of people have atypical Meniere's. But I 100% agree that, well, ma'am.
They just haven't been referred on. They've
Yes.
been told that.
What can I say? I mean, I'm a GP. I have to defend them. No.
No, I mean, they've been on it.
It's not the right thing to do. Yeah.
No. Things have moved on, and
Yes.
they've maybe been on it for 20 years.
Yes.
They're terrified of going back to that vertigo state. And so won't even, whereas, let's rule out some other things first.
Yes, yes.
Because if it is BPPV, there's much more clinically that can be done.
Yeah. I agree. You see, BPPV and Meniere's are poles apart, though. You must remember that BPPV is a short-lasting vertigo. Meniere's has to last at least 20 minutes to 12 hours. That's perfect criteria, very strict one. Otherwise, 30 minutes to 24 hours. So Meniere's is hours of vertigo. BPPV is seconds, a minute or two. So it's very difficult to confuse. Anyway, they're blurring outlines between various dizziness disorders as we know more, but we don't have time to discuss that today, at least. I don't know if I'm taking anybody else's time now.
No, it's just the lunchtime that you're encroaching in.
Oh,
I'm
well,
sure
that's
all
even
these
worse.
people. But if there is an urgent question, we can take just one more. It's 12:30, but anybody has a present question? No? You're free to go.
Thank you very much.
Thank you very much
once again.
to
Thanks a lot.
Dr. Rakesh Chopra.